Welcome back to Guns and Mental Health, everybody. It is good morning on the West Coast and good midday to everybody on the East Coast, and that happens to include Michigan, where our guest, Dr. Bob Smith, is located. I'm going to let him introduce himself, but we're here to talk about a book that he has coming up in a couple of months that'll be released, and I'm super excited about it. It's called Has Medicine Lost Its Mind? And I know there's a double entendre in there that we'll get into, but Mike's with us. He's down in Vegas. Hello. And we just got back from SHOT Show last week. That was useful and entertaining and worthwhile, but that's not about us today. It's about Dr. Smith. So, hello, sir. Introduce yourself to the audience, if you would, please, and let them know.
Thank you for having me, Jake, and looking forward to it. I practiced for about 10 years and realized my terrible ineptitude in taking care of mental health patients, and went back and then took training at the University of Rochester and have been in academic medicine ever since, focusing on primary care mental health and doctor-patient communication, basically what's called patient-centered interviewing. And I've been at Michigan State then doing lots of research work, been here since 1985, and we've developed the only evidence-based primary care mental health program. In other words, it describes how to train and conduct primary care mental health. And we've also developed a patient-centered interviewing method, which is evidence-based. So I've been in this business for a long time.
You've got a couple other books besides this one of which is the How to Interview book. Now, for those of us who are raised in the mental health, master's level professional stripe, we get taught something like that from usually from the Morrison book. It's called The First Interview, and I'm guessing that this is something similar, but you're targeting physicians in the primary care setting. I like it. I haven't looked at the book. I got your new book, but I love the concept because giving a good, robust, thorough biopsychosocial interview of all your patients, I think, is just useful information to have. But I'm curious too, how does that extrapolate into like pediatrics or emergency room settings or dentistry or any of the other, interfaces that you encounter?
I'm glad you asked that, Jake, because these skills are basic interpersonal skills. You and I use them. We should use them with our spouses, with our children, and even standing in line at the bank with the person standing next to you. These are nothing unique to, say, pediatrics or medicine or surgery. They're basically fundamental interpersonal skills. And what we did was adapt these for medicine, because medical doctors are trained just to ask questions for the most part. What we did was adapt these skills for medical education, both students and residents, and show them how to use basic interpersonal skills with their patients. But this is nothing unique to medicine. As I say, it applies widely. Basically, what it involves is determining, first and foremost, it involves listening and not interrupting a patient. But first and foremost, hearing their story as they tell it. Ultimately, most of these stories, you want to get them to emotions. Most people have emotions, but many of us, particularly men, guard them. But if you interview them correctly using so-called patient-centered skills, the emotion will come out. And then one further develops that to understand it. For example, I was feeling upset because a new person came into our office and we didn't seem to get along very well. Well, you would develop that further. Tell me more about being upset. And once you understood it, for example, upset about the guy may take my job, then you address the emotion. And this is where everybody tells you to be empathic, but nobody tells you how. And we developed a mnemonic to help doctors, but everyone, you and I, to be empathic. And the mnemonic is nurse. And, for example, somebody was upset, as we just had talked. You're upset. I'm naming the emotion. I can understand that understanding. That's been a tough time for you. Respect. Let's talk about that more. Maybe we can come up with something. That's a support statement. Those nurse statements are how one is empathic. Use these with your wife, your kids, the banker, the coach, whoever it might be that you're interfacing with. You have to listen to them, hear them. Almost everybody will tell you some emotion they've got. Then you nurse it. Name it, understand, respect, support. Now, you don't use all four of those all at once like that, but nor do you use them just once. You rather sprinkle them throughout the conversation. So that was upsetting. 30 seconds later, well, let's work on that together. 30 seconds later, it's been a tough time for you, hasn't it? 30 seconds later, I get it. And on like that. And so these are fundamental interpersonal skills that everyone should be familiar with. But unfortunately, that is not the case, particularly in medicine.
Yeah, it's outlined in the book too. I'm going to keep pinging the book because I think it's a very well written book and it's easily digested by most people. The history, we'll get into this stuff. Like you outline the history of medicine and so forth, and how we diverted. There's a template in there. It's a bullet listed template that I'm absolutely going to jack and use in my own world with my students and my interns and all the
Mm-hmm.
circles in which I run. Of course, I'll give attribution because it's proper. But my question though is it's a bit cynical, but it's the reality in the world in which we live. I think the doctors I know are crushed for time, right? And so the almost reflexive yes, but is yes, but I don't have time to go into those types of things. And my reflexive yes, but is but can you afford not to? How do you combat that type of pushback?
Well, what's shown, and it takes a while to learn these skills. We had like 6 or 8 weeks for our beginning medical students to learn them, and they don't come naturally. Some of them are counterproductive. Relinquish some control to the patient, address emotions. Most of us are not trained and encouraged to do that. But to your question, Jake, what's been found is it takes absolutely no more time. Once you've learned these skills, it takes no more time with the patient than otherwise. In fact, over the long run, it takes you less time because the patient does not keep coming back, bringing up things that you overlooked or refused to address. Once you address these things using patient centered skills, you're both able to move on. So it really doesn't take any more time, but it does take time to learn them in the first place. Having said that, though, I would encourage everyone to use these nurse skills. Ask your spouse or your kids, how does it make you feel? They will give you some feeling and then nurse it. Name it, understand it, respect it, and support it.
It looked like he was leaning in.
Yeah, no, so I love the concept. I think it's great. Wondering how does maybe gun owners are very interesting people, right? Because you hit on, okay, men have trouble sometimes showing emotion or explaining exactly what is bothering them. You take, for example, the person who's afraid that they're going to lose their job. And it's not really that a new person came into the office, right? But you got to get them there to actually tell you that. When you add a layer of my Second Amendment rights are so important to me. Does that change the dynamic? Because now you have to get through to here, but you also have this barrier when you're a man or a woman, right, coming into the office who's like, I got to be careful what I say because I don't want to be judged because I own a firearm.
And that's part and parcel of being patient centered, is to respect the patient where they are, whatever their beliefs and however they feel about certain things. You still have to be able to hear it and address it. And so they should be treated as respectfully and patient-centeredly as anyone else.
Have you ever done any work with the veteran population with the VA healthcare system at all?
Not recently, but when I trained at University of Iowa, we spent a significant amount of time in the Veterans Hospital there. So I'm familiar with the Veterans Administration and the quite fantastic work that they do, but I have not worked with them recently.
I only ask that because we do a lot in that circle, and some of the friction and frustration I think comes with the lack of bedside manner that's often found within the veteran community. At least they perceive that they're not being met where they are. In enough interactions I've had with VA clinicians and clinical staff, I don't think that's maybe the case. But yet again, I think it's a reason why we need to push people to get more continuing education credits in a good format, not just notch the box, right? So it's kind of neither here nor there.
My personal bias would be I doubt that it's veterans administration physicians. It's rather a general phenomenon. Doctors are not taught how to be patient-centered. They're taught to ask questions, to get to the bottom of it, and get through it quickly. And while many medical schools now do provide some interviewing training early in medical school, typically it's the first course in medical school in the first year. It's not reinforced after that. And they see faculty who tell them, hurry up, don't address all that touchy-feely stuff about emotions. It'll ruin your objectivity. Focus on the physical disease. And so it's pretty much beat out of most doctors by the time they graduate.
Man, that's interesting. It's got a lot of overlap with law enforcement because I used to teach cops the mental health intro and then some scenarios and evals for dealing with mentally ill subjects on the streets. And the academy wrestled with where to put that in the curriculum. The 40 weeks or whatever that they do, or I guess it's like 20 weeks that they do. It's like, do we put it in the beginning so they forget it? We put it at the end so they're already pre-programmed. Do we put it in the middle and then flip a coin? But I'm thinking too, like, in my field, I'm having to push the other direction because we're so much into the touchy feely that we almost lose focus of the goal and the objectives. And then we get rabbit trailed to the point that patients stay on the calendar far too long because we're chasing down everything that pops up that seems like a distress. And I'm like, no, stay centered, get to somewhere, solve something. So it's an interesting dynamic. I want to talk about how, medicine has lost its mind and, get into some of that, the mind body split and how we forgot it, then we reconnected with it, and now where are we today? So give the audience a little bit of an overview, if you will, about the history and the path. And the Catholic, I didn't realize that the Catholic Church banned dissection of the human brain at one point too.
Yeah, well, it's a little backdrop of this is I've been in this business, as I mentioned, since 78, and have done lots of research, and many other people feel the same way I do. I'm certainly not the only one to discover this, but basically we have developed good methods for training doctors in primary care, mental health, and improving mental health care, which is a crisis right now. It's an absolute disaster, and COVID just made it worse. Medicine hasn't done anything about this. They keep doing the same old thing focused on physical diseases. Well, I got tired of this. And so this is actually why I wrote this book, is to go to the public to get them activated and do something about it. It's a scary story. Many of your viewers and listeners have to be alarmed by what I'm going to say. Primary care doctors conduct 75% of all mental health care in the US. Here's the problem. They're not trained for this job, and the results are predictable. They overlook most diagnoses. They don't even recognize a mental health problem. The ones they do diagnose or treat are usually done erroneously. And so what happens with this is it leads to lots of unnecessary trauma, divorces, because doctors don't know to look into depression, job failure, job loss, because doctors don't know how to look into depression or anxiety that's going on, and so on, homelessness, incarceration. Many of these can be prevented if doctors were trained and knew to look for it. Unnecessary deaths, suicide deaths, COVID, or not COVID, but opioids deaths. These are prescribed medications. There have been 200,000 people die in the opioid epidemic by prescribed medications. Doctors are not trained to use those medications, much less to treat chronic pain, which is why the drugs are used. Not their fault. Don't blame your doctor. They're not trained. In fact, they'll tell you what the problem is. I talked to a couple of them the other day, and one of them said, Bob, there's no psychiatrist in my town. The other one said, well, there's a couple, that takes 6, 8, 10 months to get a patient into them. And so the message is psychiatry sees no more than 12% of all mental health patients in the US. And that's some 100 million patients. It's the most common health condition in the US. Psychology sees another 12%, but the remainder, 75%, are taken care of entirely by people like me, primary care docs. And we simply have not been trained for this. The answer to it is pretty straightforward. Train the doctors who provide the care. Has medicine lost its mind that medicine does not do something like this? But it doesn't, and that's why I'm going to the public to try to raise consciousness to this.
It seems like every time I talk to a doc in a front line setting, such as what you're describing, they also are handcuffed by not just time and the time crunch and the mill of generating revenue and stacking CPT codes, but also there's a disconnect, and everybody uses the word siloing, but there's a disconnect in making a proper warm handoff to a specialist like myself, the marriage and family therapy, the professional counselor, the clinical social worker, because they simply don't know that we exist. And I think that's because we're locked into our own zones of having to slug it out 35 patient hours a week, and we just can't get out into the community and make these connections. It seems like the medical schools and the graduate schools should be connecting in some meaningful way. But I like the appeal to the public. Do you think that there's a next step beyond the NURS technique that we can integrate into the medical setting to make them more competent and comfortable in referring to a specialist once they hit the limits of what they can do in the office?
Yeah, I mean, to your earlier comments, first is psychology, social work, all of these dimensions that are valuable in taking care of mental health patients exist outside of medicine. They're poorly integrated into it. And in the Has Medicine Lost Its Mind, I advocate in there not only training primary care doctors, but training more psychiatrists, but also integrating psychology, social work into medicine. This has to be done. Otherwise, we're simply all existing out here in different places. And many doctors don't even know of the psychologists or social workers in their communities.
Do you think that's on us to get out of our way and take some business lunches and spread some business cards the way that the pharmacological companies do, or is it on the schools to do? Everybody should probably get on board, but what do you think the easiest way is?
I do think it would help. I mean, when I was in practice, I got to know some psychologists and social workers and other counselors, and not only learned a lot from them, but learned when to refer to them, and they would sometimes tell me then what I needed to do, and it worked. You work kind of as a team, but it does take getting to know each other. I mean, that's the first and foremost that has to happen right now. Yes, so it would help to go out but everybody's busy, and so that always stands in the way. You're in different buildings, different parts of town, and so on and so forth. But it can be overcome if you work at it. But it will not answer this bigger problem.
It's almost like we need a messaging campaign, maybe from the state people or the county people, the public health folks, to galvanize this. I mean, we're living in Nevada, which is largely known as the doormat of all healthcare and has been for years because we just can't get out of our own way. But our governor just recently in his State of the State address announced a new Nevada Health Authority, which is going to break up our Department of Health and Human Services into something more nimble, it sounds like. And maybe there's an opportunity, at least in our state, to move that forward. I want to talk a little bit about the mind body thing, because that has been, I think, just in my short 15 or so year career, it seems to have swung, the pendulum has swung from nobody talks about it to now everybody talks about it, but they don't really have the proper language to articulate properly the connection between psychiatric ailments and how they manifest physiologically. Give us a rundown of that, please, and your take on that.
Sure. And fortunately, as you're pointing out, Jake, lots of people are starting to be aware of the terms mind and body and the fact that they go together. Here's the problem in medicine. Start out back in the time of Hippocrates. This is the 5th century BC, up until the scientific revolution in the 16th century. The mind and body were joined, just like this. Everybody accepted that. Doctors saw people with bipolar disorder next to people with headaches, and they would see what they call melancholia, and mind and body were joined. Comes the 16th century, the scientific revolution. Now, understanding that the church, the Catholic Church, had been all powerful in Europe throughout from about 2000 on up to this time. They ran everything, and it was in medicine called the Dark Ages of medicine because no advances were made. This is also the time when other sciences were awakening. Newtonian physics developed at this time, for example. And so the medical people, the medical scientists, wanted to get more involved and start being active scientifically. And what was the basic science of the day? Human anatomy. Well, the Catholic Church had long proscribed, that is, they saw human dissection as blasphemous. It was prevented. And so, up until this point, doctors dissected goats, pigs, cows, and the like, and simply inferred that what they found there was what human beings were like, which of course was wrong. And so, doctors and medical science was really pushing. And so what happened in 1537, Pope Clement relented and he said, you may now dissect the human body for educational and professional purposes, but with one proviso. The head must be decapitated from the body and turned over to church authorities before the dissection begins. They would bury it and give it proper services and rites. You get, the Pope said, the rest of the body from the neck down, the physical body. The mind is ours. It's the source of the soul, the spirit, emotions. This belongs to the church. And that basically is what launched the mind-body split. Now, thereafter, chemistry flourished, physiology flourished, all focused just from the neck down on the physical body. The church maintained control of the mind. Next century now, Descartes, who I'm sure you've heard of, come along. And the same idea, I think, therefore I am, Descartes said. And what that meant was that was unique to his mind. Only in his mind did that occur. No one could observe it, no one could see it. And so this became the philosophical basis supporting the mind-body split and was far more powerful than the previous century in establishing it. This is what locked it in. And then John Locke, Thomas Hobbes came along and did the same thing. Many people view what happened at this time with the philosophers as a so-called grand compromise with the Catholic Church. Science wanted to improve. And so the Catholic Church compromised and let them have the body from the neck down. But they kept the mind, spirit, the soul, the emotions. And thereafter, medicine all went on that track of physical body only. And we can go on from there. I can describe, if you'd like, what happened then in clinical medicine. It wasn't translated into clinical medicine until the 18th century and didn't really have any therapeutic benefit until the 1900s. Sulfa was discovered, ether, chloroform, all of these things came about and worked wonders. Then through the last century, polio vaccines, all sorts of public health measures controlling disease, joint replacement followed, heart replacements, all of that. We're now down to the genetic level. Eyes show what's going on inside the body and so on. There's been a dramatic benefit from this mind-body split to modern medicine, to the extent that from 1900 to the end of the 1900s, life survival doubled from 40 to 80 years of age. And this is a profound success. Make no doubt about it. The mind-body split was very, very effective. Downside, however, was that as people lived longer, they're now not dying at 40, they're living to be 60 and 80. Mental health, always been there, mental health problems have always been there, but they're now surfacing more prominently. And another thing happened. Chronic diseases, diabetes, heart, stroke, COPD, all the chronic diseases you're familiar with, replaced the acute diseases that medicine had cured that led to the prolonged life survival. And so it's obvious how splitting the mind away from the body is detrimental to mental health care. That's obvious. Mental health care was not even on medicine's radar screen. The role in chronic disease is different. So medicine's forte is physical disease. How could physical disease be impaired by the mind-body split? Very much. One example, 17% of all chronic physical diseases have a co-occurring mental health problem. And that's some 30 million people. This is a diabetic that's maybe about to lose their leg, or somebody with heart failure that can't play golf anymore. These people, when they are severely disabled with physical disease, become depressed, anxious, often use addicting medications. These are all psychosocial issues that medicine excludes. These must be treated if the physical disease itself is to be addressed. Medicine doesn't do this. Data show that only 12% of these chronic physical disease patients with co-occurring depression are even treated. And when they're treated, it's usually by primary care doctors who don't understand exactly what to do. But it gets even worse than this. Remember, the mind is excluded, and that means all psychological and social, environmental, are excluded by medicine. When you have a chronic disease and want to treat it, let's say somebody's had a heart attack or somebody's got diabetes, you have to be effective, to treat the lifestyle factors that go with it. Cigarette smoking, alcohol use, not exercising, overeating, and so on it goes. All of these factors, all of these lifestyle issues are the very psychosocial material that medicine excludes. And so they don't get addressed. Now, of course, the doctor says you have to quit smoking, or they say you got to get more exercise. That doesn't do it. That requires much more intensive skills. They're called motivational interviewing skills that have to be taught and then deployed by the doctor. Okay, so
Yeah,
doctors
go
are,
ahead. Keep going. Keep going. Keep going.
yeah,
I don't want to interrupt you.
interrupt me whenever I can go
No,
on
no,
and
no,
on.
no. This is
But
good.
it gets even worse, Jake. These same psychosocial factors that are not being treated, why don't we prevent them? 80% of all heart disease and diabetes can be completely prevented by preventing cigarette smoking, alcohol abuse, lack of exercise, overeating, and so on. All psychosocial factors. These addressed properly by the medical profession and public health, which needs also to be brought back into medicine, can be prevented. 40% of all cancers can be prevented. But no, medicine doesn't do that. It excludes all these psychosocial lifestyle factors. They just wait until the disease occurs and then treat it. And it's a prolonged treatment usually, and an expensive treatment. Another downside then of this, what if you prevented even 50% of all chronic diseases? What would happen to your hospitals? They'd be half empty. What would happen to your insurance companies? They'd have no business. What would happen to your pharmaceutical houses? They'd have half the sales of these new obesity drugs that they're selling. What about equipment houses? there wouldn't be as many joint replacements to do, and so on and so on. And so what has happened is that the mind-body split is the most proximate problem that has come along. Just wait for disease to happen, and then we'll address it. The so-called medical industrial complex, hospitals, insurance companies, drug houses, equipment houses, have piggybacked onto that and are now making a fortune out of things just the way they are. They do not want to change what is now going on, and it is a crime. Don Berwick, in a nice article in JAMA, titled it Salve Lucrum. And what that means is profit reigns. And many people are being very concerned that the medical industrial complex, now with the venture capitalists getting involved, is devoted more to profit than to patient care. Now, this is not true, in my opinion, among garden variety doctors on the front lines, deans, all of the medical people within it. They're simply imbued by the mind-body split and have led to this. They are not in this for money, in my opinion, at least in the vast majority of instances. What has happened is that the entrepreneurs have gotten into medicine and they are making an absolute fortune. I could go on and on.
Yeah, it's poignant. And Tovis in our chat raises a question of, there's also money in alcohol, food, marijuana, tobacco, and so forth. And those are big industries as well that have an incentive structure that relies upon the continued illness of people and their poor coping skills in the form of those substances that they would consume. I can't shake the idea that, Carl Jung has this word called introject, and introject is an unquestioned belief or assumption that just gets pushed into our psyches. And I think that the schools themselves are introjected with this idea that the mind and the body are not the same. So we're battling many things here. We're battling a long-standing, deeply impacted belief structure. We're battling revenue streams, and we're battling habit. Tovis, he says, is it like this in other nations too? And it's a great segue, because I was going to ask about, you've done a nice overview of what we would refer to as Western medicine, but Eastern medicine's been around a long time, and they do integrate soul, spirit, religious affiliation, and now we've seen the emergence, probably too late, in the game, but we're going to tackle it anyway. The idea of psychedelic substances that unlock consciousness from unconsciousness by toggling the default mode network and so forth. And I don't know if you have an opinion on that and how we can integrate this globally.
Yeah.
Do we see this in other nations, or is this unique to the West?
It's unique to Western medicine. I mean, Western medicine began in Europe. It only came here 150 years later. And so this all began in France, in fact, but spread then through Europe before it came here. But just one comment, I probably shouldn't say this, but your term about introjection from Jung, who I love, I use a different term. It's brainwashed.
Yeah, I'm fine with that.
Medicine, it's unconscious, it's subconscious is what I call it in the book. This is so introjected, so brainwashed, this mind-body split into medicine, it doesn't even consider the alternative. It's the proverbial fish out of water. It doesn't understand water. It has no concept of water or of out of water. And this is what must be overcome. Eastern medicine, I know very little about it, although I know people that have worked in it. Much of what they do links the mind and the body. My understanding is that much of Asian and Eastern nations have begun adopting much of Western medical principles that these do. In fact, within medicine, osteopathy, nursing have long advocated bringing the mind and body together, but it has not prevailed by any means.
Yeah, that gets to Tovis's first question, which is, are there differences in approaches between MDs and DOs? Are there?
Not really. I can say this with some authority. I'm an MD, but there's a DO school at Michigan State, and we have worked together with them extensively. I've trained many of their people in our residency, in fact, and the difference, to me at least, is not discernible. The only difference they have in training is that DO students take a brief course in osteopathic manipulation. But my understanding from the DO people is that does not make them qualified to practice that once they're out. To really be effective, from my understanding, in osteopathic manipulation requires specialty training afterwards. But short of that, the training is exactly the same. It's just loaded with physical disease issues, one after the other. I must say, I'm partial to osteopathy. I had a severe back problem for some time and had just kind of gotten used to it. I went to see one of the premier osteopathic doctors, Phil Greenman. He worked with me for a few times and have had no trouble since then. This has now been some 20 years. So I'm very favorable to that profession.
So, in your opinion, then, if the system is, we'll just say, stuck, that's why you're appealing to the
That's
people,
right.
the consumers. We have to
Medicine,
advocate for this.
yeah, medicine has heard about this time and again since at least the 1960s. There was a huge article came out back, it's around 2000. It was called Primary Care, the de facto mental health care system, citing the same things I'm citing right now. George Engel articulated the biopsychosocial model in 1977. Medicine is fully aware of this. It's in most of their mission statements anymore, but they don't do anything about it short of some of them teach patient-centered interviewing early in medical school. And so the point is, and the Institute of Medicine has come out and said medicine needs to do more. They're saying the same thing I'm saying. Basically, we need to do more about this. And I've got in the book, I think there's 17 references to august bodies recommending just what I'm recommending. And so with medicine, it's just in one ear and out the other. They absolutely nothing. Training in mental health care has not changed since 19. Medical students receive no more than 2 to 3% of total training time in mental health care. And this is on average, 5.1 week experience in psychiatry in their third year of medical school. It's the only supervised experience they get at all. And unfortunately, this is usually on inpatient psychiatry, where they see patients with schizophrenia, psychotic bipolar disorders, severe personality disorders, and these patients are completely unlike the ones you see in primary care with garden variety depression and anxiety. And so residencies then are even worse. Family medicine is the best, and it has a smattering of mental health care within its training. No other residency, somewhat in pediatrics, I should say, does some, but no other residency does anything with it. My discipline of internal medicine gives a grand total of 17 hours per year, and it's all a lecture, noon hour lectures for people come late and leave early. And so that's not supervised training. Lecture material doesn't do it. I mean, if you talk to deans and program directors saying the kind of things I'm saying, like you don't train in suicide, you don't train in opioids, you don't train, they say, oh, we do. But when you pin them down, it's just a lecture here and there. They're still doing no more than 2% of all training. And what's missing is supervised training. You need a skilled faculty person. You need a patient with the problem and working with them repeatedly. And that's what medicine does. Medicine knows that because that's what it does with all these physical diseases. That's what they're doing for 8 years, 4 years in medical school and 4 more in residency. They know it. They know how to teach it. It's just off the radar screen. It's subconscious. They're brainwashed away from addressing mental health, which happens to be the most common health condition its practitioners will see in practice. It's more common than heart disease and cancer combined. Mental health. And think of this. Medicine is graduating people who are unprepared to take care of half the patients they will see in practice. Has medicine lost its mind?
Yeah, I'm thinking about like the intro when I looked at the book, the you come out swinging, right? Saying like
Yeah.
1 out of every 4 family members probably will
Yeah.
be suffering from a mental health issue. And obviously, this organization that Jake and I run is all about getting upstream to prevent the unpredictable. Something you said earlier, though, and part of this is selfish because I have some people in my life that have had issues or have issues. You said something like co-occurring, right? Let's take, for example, someone that might show signs of schizophrenia, but also might have an Adderall addiction. Like, how do you handle that? It's a chicken and the egg thing, right? It's like trying to figure out what came first. Obviously we want to get people off of a drug that they're abusing, but that drug at the same time, that person probably thinks this is what keeps me normal or this is where I feel at home. Like, how do you address these situations, especially when maybe you see like a patient that isn't ready to accept that they have a lot of issues or they have an issue? And this is more, like I said, this is for both of you guys.
Yeah. Yeah. It's difficult. And one thing, I mean, to go back to the theme I'm expressing, primary care doctors lacking training in anything don't even recognize those as mental health problems until someone is just overtly psychotic in their office or someone who is shaking from drug withdrawal. That's just not their boat. If they were trained, it's been shown with schizophrenia that it can be diagnosed 4 to 5 years earlier if it's recognized. And these people come to the doctor to primary care. They don't go to psychiatry. They're coming to primary care. And if that doctor is trained, they can recognize the preliminary symptoms that will eventually point to schizophrenia: loss of interest, poor school performance, withdrawing from friends, and what it may be, and can be on top of that and get to earlier diagnoses. They can spot the drug use and certainly not be prescribing the drugs that are being abused, which they now are not always well versed in doing. And so, but the type of problem, Mike, you're talking about is somebody that's schizophrenic and addicted on Adderall. That would be in the realm of psychiatry. There are enough psychiatrists to handle referred major mental problems. In other words, primary care needs to be trained not to be psychiatrists. We don't want to train them all as psychiatrists. We want them to train as to be as competent in mental health care. And basically that's depression, anxiety, and substance abuse. To be as competent with that as they are with diabetes or thyroid trouble or delivering babies. That's what we want. And so these doctors can then address the easier mental health problems. 60% or so of depression problems will respond if the primary care doctor knows what they're doing. The ones that don't respond would then be referred to psychiatry. Now, none of this is anti-psychiatry. We need more psychiatrists. They simply are not in great enough numbers now or ever will be to handle the mental health problems of the entire country.
My take, Mike, is that we're ill-equipped to adequately diagnose, and I want to use that loosely because we're literally prohibited by statute from diagnosing physical ailments. And what I'm hearing is that it's almost like we need to tack on an extra semester of preceptorship to the doctors to shadow somebody like me and have me train them. And for me and my people to go shadow a doctor's office to start looking for some of these signs and symptoms that are very obvious. Because I mean, literally just this week, just yesterday, I had one of my interns, we had a chat about how he was, he he was too quick to refer out because he perceived some neurological issue that simply through the grandparents' testimony of this 4 or 5-year-old presumed that he wasn't adequately equipped to treat. And I said, well, we don't know that it's a neurological issue, and we probably won't ever find out because unless we send them to Palo Alto for some overly expensive series of tests that they're not going to get, we're not going to know. Or, if you send them to a neuropsych for an eval that they won't get because they're 9 to 12 months out and it also costs $2,500. What we have to do is default to, you didn't come out of the womb this way. It's probably not a structural deficiency in the brain. Let's work on environmental and social issues, shore up the parenting, get them anchored in something bigger than themselves, like a spiritual faith. Let's do some consistent parenting and put some guardrails on the child's behavior in the home, and then see where we go from there. But ultimately, I mean, this is a recurring theme in our lives, in our world, in the non-medical realm, where somebody comes in and says, I have fill in the blank issues. I see my doctors sporadically. They don't know what's going on. And I'm like, well, it's easy to me. This is a both and. It's not an either or. Start change your diet, start exercising, get some sunshine, make some friends, pick up a hobby. And oh, by the way, take care of your MS. And it's really, really challenging. I'd love to see a semester extra in all disciplines. I know what I'm asking here, of course, too, but that seems to be the way we battle this. Of course, we have to fight the reward structure that's incentivizing everybody not to do that.
Yeah, no, that's it. You're alluding to something here that's worth emphasizing: physical disease. When physical disease, I mean, what tripped this up in my mind is there would be people that doctors would see with so-called unexplained physical symptoms, chronic pain oftentimes.
Fibromyalgia,
something like that. And so the doctor wouldn't know, they didn't find anything because they're interested only in physical disease. Well, they don't find anything. So then if they could get one, they would send them to a social worker, psychologist, psychiatrist. Well, they then get to the psychologist and they say, you need to go back to your doctor to find out what's causing the physical symptom. And back and forth they go. And so nothing ever happens. And this is why, to your point, these need to be integrated. I've worked with a number of psychologists and other non-physician people in medical settings, and they're just shocked to see how radically different it is than sitting off in an office on the other side of town doing psychotherapy. It's quite different. And this is why all of these disciplines need to be brought into medicine, at least in my opinion. And physical disease problem is seldom recognized. One of the problems in medicine, they're focused on physical disease. Patients come in with physical disease, and that's all they attend to. These people, I think I mentioned this earlier, who are debilitated, they're about to lose a foot from an amputation or their diabetes. They can no longer play golf. They can no longer have sex. They're so sick from their heart failure or their emphysema. These people get depressed, but doctors don't know that. These patients with physical diseases do not come in and say, Doc, I'm feeling depressed because I can't play golf. They simply come in and say, the pain is getting worse and worse. They don't volunteer it. And what has to happen is these doctors have to be trained to the extent they know when they see somebody with debilitating physical symptoms to ask about depression and anxiety. And simply it doesn't happen. This is actually a problem also with mental health professionals. They see somebody with physical complaints, they assume a mental health problem is going to present with psychological complaints. I feel depressed, I'm anxious, I'm hearing things, and so on. They don't oftentimes. They present with physical complaints. And this, in fact, in my primary care mental health textbook, it's the first 3 chapters, is the role of physical complaints in psychiatry. In fact, those are the 2 books right back there. Can you see them? The ones facing this way.
Yeah, Psychiatry and Primary Care.
Yeah, that's the one. Yeah. And the other one is the interviewing book we talked about.
Let me throw this at you because I could talk about this for hours and hours, I'm sure, and I don't know how long the audience wants to stick with us. But selfishly, I will have you on again for Noggin Notes so we can explore some of these. Somebody who's been practicing, as long as I've been alive, it's a rare opportunity to pick the brain of that person, and I'm curious what your thoughts are on this particular angle I'm about to tee up. Historically, I'm under the impression that it's scary to bring up in a medical setting the mental aspect because the patient will often say, "What are you telling me? This is all in my head." And I've read enough John Sarno and William Glasser to know that used to be a thing. Those guys are a little older. I think they're both dead now, actually. But is that still a thing? And the flip side of that is we're afraid to bring it up in our own setting and say, hey, maybe this thing that you've been dealing with, this chronic pain in your shoulder or your elbow or your indigestion or whatever it is, may be caused by your psychological ailment because the mind absolutely will
Yeah,
produce physiological effects. I mean, look no further than imagining biting into a lemon. You're going to salivate even though there's no lemon present. So we know the mind can create physiological symptoms. Is that still a thing? And if so, how do we get ourselves to be bolder enough in these settings when we're directly
yeah.
facing the patients in front of us to say what needs to be said in a kind, compassionate, but firm way? So, two questions wrapped into one.
Yeah, no, it's a big problem. In fact, when I was in practice, is when I first got introduced to it. I saw a lot of. I was then totally imbued just in physical disease, just like everybody else is. So I'm not critical of any of these people. But I would see people sent in to me with. I was a consultant with chronic pain, and I would work them up to who laid the rail and find nothing. And they say, well, the good news is there's nothing wrong. But this is an insult. You think this is in my head? And that did not go well. And so people have long been fearful of implying things are in patients' head, particularly with chronic pain, where there's no underlying explanation for it. And in my opinion, this can be handled very nicely in people who are trained. And you can very, in a patient centered, empathic way, explain to someone that we're not finding a tumor in your back and there's no slip disc there. And so the good news is there is no problem there that needs surgery. That is good news. And they may say, you think this is all in my head. And you say, no, it's in your back. But if I had as much trouble as you have had with this and being so disabled, I would also feel depressed. And I think that's part of what the problem is with you, is that you have depression. Anybody would be with this much trouble. And so people can be trained in overcoming that bias. I mean, society itself has a mind body split. Society, most people do not want to be thought of as having a mental health problem. It's so called stigma. And and people don't like that. And so one has to be very careful how it is presented to them from a biopsychosocial perspective and understood from a mind body link. It's perfectly normal, and that's what you have to convey to them, and that the treatment is different. It oftentimes has been a problem when doctors don't know to do this. Patients just keep insisting on more tests. Once the doctor orders tests and they don't find anything, the patient wants more tests, or they want a repeat of the one that was done 6 months ago. And these are MRIs that cost $1,000 a piece. And so it's a critical question, Jake, that you're raising, and doctors simply are untrained in addressing it.
You know, a big part of what I do is emotional functioning. I have a whole video series on it, and I explain the 10 core emotions as Izzard has researched. And my working theory that nobody's yet pushed back on, so I just keep going with it, is that if you don't attend to your emotional functioning, the neurochemicals that get excreted in an instance of life presenting as life does, those chemicals will not push through the system and be discarded in an appropriate way. They'll stick at a cellular level and create physiological ailments. Do you have anything that would change my mind about that, or am I free to keep pushing that and say,
No,
hey, maybe work through this?
I'm very interested in this. This is part of the next book I'm writing. Is emotions are the fundamental protective mechanism that we have developed, according to Darwin and most people that think about this. They are governed by what you're talking about, neurochemicals that circulate around in the blood, just like my fingers are doing here. And they're always in varying balances and monitoring what's going on. If a threat comes in, say a tiger walks in the room, the neurochemicals go way up like my finger just did. And you then act. And they go back to being at normal monitoring level. And so this is a fundamental protective mechanism in human and in animals as well, is that we monitor our environment mediated through emotions. Now, if it's not an emergent situation, like a tiger walking in the door or somebody walking up to you with an automobile, you're about to get hit. One perceives the environment, experiences the emotion, and transposes it into a feeling. This is what Damasio talks about, is transposes this into a feeling where you then can process cognitively and decide what to do with it. But at root, emotions are critical as the fundamental protective mechanism we have in navigating, not just when tigers and automobiles are in our future, but how we are interacting with each other. My boss looked at me askance. Oops, there goes that one up. Why did she say that to me? Oh, that one's up. And then we process that and it comes down. And so all the way up Maslow's hierarchy of needs, emotions are mediating that and mediating our integration into society.
Kevin and Mike are probably just jumping out of their skin because they probably know that you're making my day by validating everything that I've been teaching for many years. And it translates directly to children, especially, but also adults, because children age, who grow up in chaotic, constantly frictious environments whereby they don't have a space that's, for lack of a better term, safe enough for them to express the emotions that they're feeling because they're chronically
Yeah,
invalidated. And this comes from abuse and neglect and violence and all sorts of things, poverty. And then they grow older and they don't attain the skills to push through, like you described, and reasonably, rationally from the frontal lobe make sense of what they felt and then let it go. So there creates a stacking effect of sorts. Then that residue continues all the way through life. And then we end up with chronic diseases, chronic
that's right. That's
psychological
right.
issues. I'm excited for that book. When's that coming out?
Yeah, I had a friend the other day, Jake, and I'm not speaking out of school here because I think it's something that she would let me put out on the table. But it's when I text you that thing. What's worse, Jake? When someone doesn't know they have mental illness and they refuse to accept that, or someone who recognizes that they have issues but makes it define them, right? Like, now I am bipolar, so all my behavior is excused because you have to accept the fact that I'm bipolar. And Dr. Smith, Jake preaches a lot that mental illness can be overcome no matter what, which is, I think, is a great message of hope. But what are your thoughts on someone that is accepted that there's something wrong, then gets this diagnosis, but doesn't move off of the spot, like kind of stays in it?
Yeah. No, I think that can happen. And that, in my opinion, is where the person would need psychotherapy, to working with that, to first establishing a good relationship, of course, to get the patient to trust you and work with it, and then gradually helping to work out of that identification, so they have an identification as a person, not as a disease. You see the same thing in physical disease. There will be people who, especially with long-term illnesses from childhood, like rheumatoid disease or diabetes or something, who identify as a arthritis patient or as a diabetic. And it's a critical issue, is that they are able to identify as them, not as a disease. But it takes psychotherapy to do that.
I don't know your particular religious bent, if you have one at all. I mean, I follow Jesus to the best of my ability, so I have a Judeo-Christian worldview, but I'm also sensitive to any other interpretations. But at the core of it, I can't, I have a tough time moving off the idea that we're divine creatures with infinite capacity, and we're not meant to be locked into labels. Therefore, we have infinite potential to do lots of things, including recover. So if God made me to do certain things, probably misery is not supposed to be permanent. And I approach it with that that tilt, and it usually is received pretty well, regardless of what people believe in higher powers and so forth. And I just say, if this isn't working for you, do you think you can at least dream of something different? And if you can visualize it,
Yeah,
then it could
yeah.
be achieved. And that works pretty well. I'm curious your angle on spirituality and its importance in resolving many of these issues.
Yeah, spirituality is critical. We've written papers on it, and it becomes another type of relationship that one establishes, whether it's belief in God or whatever religion, or maybe just generally in having a transcendent awe of the universe, but believing in something greater than yourself. And I think it's important to foster that. It is getting lost in this society, unfortunately. Churches, sometimes at their own fault, seem to be losing membership. Many of the pastors, ministers that I have known have been very, very effective people, not just as pastors, but as human beings working with their own parishioners, and have often referred people to them and have recommended that as a source of support. So it's a critical dimension. I was closely related for a while with the Fetzer Institute in Kalamazoo, Michigan. There is probably no one more knowledgeable and effective in conveying this than they are.
You mentioned Maslow's hierarchy earlier, and I'm wondering if I just kicked this around with a friend the other day. I think that self-actualization has almost disappeared, if it ever existed, in Western society as a concept. Now, there's lots of reasons for that. There's instant gratification, there's social media, there's distractions galore. But I think that also Western medicine plays a role in this when we've taken out the idea that human beings are deeper than their outward behaviors. And is that a thing? Have we lost the idea of truly self-actualizing beyond simply behavioral outputs?
I hope not. Another term for self actualization is growth and development. We do it from infancy on up through, but adults do it also. Adults can grow and develop. And it comes back to what you're talking about with emotions. It's more complex than this, but the first thing you have to do is recognize your emotions on a day to day life via by journaling or meditating, however you might do this, or with a good therapist, and recognizing these things. That's the essence, I think, of psychotherapy. At least insight type psychotherapy is to promote self-actualization and growth. And I do think people can go through the Maslow scale. At least I hope it's not getting arrested. We're in trouble if it is.
Yeah, my concern is that the behavioral therapies, the BTs, have taken over my realm because they're quote unquote evidence based, and evidence is often measured quantitatively by outputs, and then that
Yeah.
begets more funding. And so we've almost entirely lost the psychodynamic approach, which does do the deeper work into one's psyche, soul, mind, and we're just time plus matter plus chance
No,
people walking the earth instead of deep human
it's
beings.
it's a psychodynamic, psychoanalytic approach that I cut my teeth on, as it were. That's why I got interested in Jung, and then when I was at Rochester, more so in Freud and subsequent people. But to my mind, and this goes right back to emotions, the emotions guide that process, and it's powerful if it's done right.
Yeah, Kevin keeps reminding us of how long we've been going, and I know we want to stay in that little like hour to hour and 15 pocket, but This has been really great, and I'm excited to chat with you again in a week for Noggin
Well,
Notes.
I'm looking forward to it. Thank you for asking me. This has been a great
Yeah.
discussion.
How do people reach you if they want to?
My website is robertcsmithmd.com, and it's a new website that's just coming up today.
Really? So the old one is going to be no more?
The old one with my picture sitting there is, if that's the one you've got, is no more.
Right on. Well, that's cool. Well, thanks, Dr. Smith. I really appreciate the time. This was really, I mean, my biases were confirmed. My confirmation bias is on tilt. I love this conversation because it spoke to a lot of stuff that I just had rolling around in my mind. And it's nice to talk to somebody who's a complete stranger, but affirmed a lot of it.
Yeah,
Mike, you got anything to leave with?
No, I recommend getting his book. Unfortunately, it was coming off SHOT Show, so I was only able to kind of skim it. But I look forward to doing a deeper dive into it. And I think that from so far from what I've taken from it and talking to you, I think it's an excellent book, and I think a lot of people could benefit from it.
Yeah, the public has to be activated. Medicine, we cannot afford for medicine to keep going like it is. It's simply off the tracks, and the public has to get activated. This book tells how. On my website, there's a spot on it on the first page, down at the bottom, so that people can write the president, appropriate people in the Surgeon General's office, appropriate people in the National Academy of Science, as well as your congressmen and senators. And so I'm not sure that's quite up yet on the website, but it will be soon if it's not now.
Well, you can pre-order. It's called Has Medicine Lost Its Mind? Robert C. Smith, MD. It's available on Amazon. It's about $25 or so. Pre-order it. It's available in March. And we thank you for your time, sir. And I look forward to next week. On behalf of all of our sponsors and our supporters and our audience, please share this so other people can get well also. On behalf of the entire WTTA family, we wish you great mental wellness. Bye-bye.